So this is chapter 17, dealing with heart function. We talked a little bit about it in the previous podcast. We'll discuss cardiac output and get into what the cardiac cycle consists of. We'll talk about Starling's law, and we'll talk about how cardiac output is related to activity level. We'll talk about pre and afterload and define heart failure, and talk about left and right-sided heart failure. So the first thing we want to review is the cardiac cycle.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
Remember that the heart is not under conscious control. And even though the heart would beat without any nerve leads to it, it does have a property known as autorhythmicity, which, if the heart were beating on its own with no connection to the nervous system, would run at about 100 beats per minute. But because the autonomic nervous system governs the rate at which the heart's pacemaker fires, the average rate is around 75 beats per minute. So the parasympathetic lead to the heart is the vagus nerve, which is the 10th cranial nerve, and the sympathetic lead to the heart comes from postganglionics that are found in the thoracic spine, okay, whose preganglionic neurons originate from the thoracic spine. Essentially, what the sympathetic division of the autonomic nervous system does is it allows the heart rate to increase in order to compensate for a higher rate of activity, and that's to get more oxygen and nutrients to the tissues that are carrying it out so that the activity can continue, right? So when you're using your skeletal muscle at a greater rate, you're consuming more oxygen and more fuel, and as a result, you need a higher rate of blood flow to those particular tissues. And we already know from talking about the autonomic nervous system that when the sympathetic division is exerting the greatest amount of control, that we actually increase blood flow to the heart, the lungs, and the skeletal muscle, in addition to accelerating the heart rate. And we reduce blood flow to the digestive, the urinary, and the reproductive systems. And the net result of that is to increase the pressure in the whole system, but that helps to route the blood to where it needs to go most immediately. Part of doing that is increasing the heart rate, and it's also going to have an effect on how powerful the contractions of the heart are. Okay, and that's called contractility. So when the sympathetic division of the autonomic nervous system is working, not only does the heart rate go up, but the heart squeezes harder and ejects more blood with each beat. Okay? When the parasympathetic division is exerting its effects, the heart rate goes back down to its resting rate of around 75 beats per minute, and we route blood um, back to the digestive, the urinary, and reproductive system while maintaining rest levels of flow to the heart, the lungs, and the skeletal muscle. So you can see how the sympathetics are going to lead to the heart, right? They're going to talk to the SA and the AV node, and they're also going to have an effect on how hard the myocardium squeezes. So the effect of the sympathetic, as we discussed, is to raise the rate, right? And the effect of the parasympathetics is to bring it back down to resting level. An interesting point is that if there were no nerve leads to the heart's intrinsic rate is 100 beats per minute. So at rest, the parasympathetic division serves as a braking mechanism that keeps the heart rate around 75. The sympathetic division of the autonomic nervous system is going to increase SA node activity and increase the heart rate, because remember that the SA node contains the cardiomyocytes that already fire at the fastest rate at rest. And so by essentially releasing them from their resting rate, the heart rate can speed up, because the wave will pass from the SA node to the AV node, down the interventricular septum through the bundle of His and the bundle branches, and up the Purkinje fibers in a continuous wave of electrical activity. Okay. So what this does for us is it increases the cardiac output. The cardiac output is just the product of the heart rate times the stroke volume. So the heart rate is the number of beats per minute, and the stroke volume is the number of milliliters per beat. And so since both of those increase under sympathetic stimulation, the cardiac output rises significantly. Excess sympathetic activity causes tachyodysrhythmias, where the heart rate can become rapid and irregular. Drugs or hormones that mimic the effect of the sympathetic nervous system are called sympathomimetics. Note that when a person's in shock, the sympathetics can fire to compensate for by raising blood pressure. So normally in shock, one of the things that happens is that the blood pressure will fall, and a response to that through negative feedback is to try and bring it back up. In the parasympathetic division, the vagus nerve hits the SA and the AV node and slows the heart rate down while not having much of an effect on the strength of contraction. But we should point out that when the parasympathetic division is the primary division, the sympathetic effects are usually reduced, and so the result of that is to drop the strength of contraction. So the amount of squeeze, the strength of the squeeze does drop, but not from a direct effect of the parasympathetic division. Okay. A vagomimetic drug like digoxin slows the heart rate and the speed of impulse conduction, while a vagolytic drug like atropine increases the heart rate and speed of conduction through the heart. As a result, atropine can reverse the effects of vagal discharge. Note that if the vagal discharge is interrupted, the heart rate goes up to 100 beats per minute, while intense vagal discharge can decrease the heart rate and the speed of impulse conduction, and this causes bradydysrhythmia, the worst of which would be a heart block, where the signal does not manage to make it to the ventricles, and that results in no discharge from the lower chambers, and that's an immediate medical emergency. What you're looking at here is just the formula for cardiac output. Okay, the cardiac output in a healthy heart can increase 4 to 5 times under sympathetic effect, and this is called your cardiac reserve. Your total blood volume is about 5 liters, so your whole blood volume passes through the heart every minute in an average resting human body. Patients that have heart disease often have little or no cardiac reserve. As a result, um, they'll feel fatigue and pain if they persist with intense exercise. The heart rate is just the number of times the heart beats each minute, and that's set by the SA node firing rate, while the stroke volume is the amount of blood that's kicked out with each ventricular contraction. And you can alter the cardiac output by changing both the rate and the stroke volume. So if we look at typical heart rates, you're talking about 72 beats per minute, and you're talking on average 70 milliliters per beat. Okay, so you multiply 70 by 70. All right, you're going to come up with 4,900, and that's about 5 liters going through the heart at rest per minute. Okay, the force of contraction is affected by your epinephrine levels. The epinephrine actually causes more calcium influx into heart muscle tissue that results in more cross bridging, and the result is greater force. Okay, so that's one of the mechanisms that that causes the strength of contraction to go up. Remember that when the sympathetic autonomic nervous system fires, not only do we have discharge from the postganglionic sympathetics, but we also have epinephrine in the bloodstream from the adrenal medulla. And so oftentimes, even after the fight or flight situation is resolved, the heart rate and the stroke volume will stay high for a period of time during which the epinephrine gets cleared from the blood. And so that's one of the reasons that you stay amped up even after the immediate threat has subsided. Starling's law of the heart just states that the more blood that flows into the heart, the more blood will flow out. Now this makes intrinsic sense, because if that weren't the case, if the heart kicked out less blood than it took in, then it would eventually rupture. Okay, but there's a reason for Starling's law. Okay, the greater the amount of stretch in the myocardium, the more effective the squeeze is going to be, because there's an optimal amount of stretch that causes the cross bridging in the cardiac muscle tissue to be capable of generating more force. All right, so that's one reason that you get more out as you put more in. The other reason, of course, is that if you're putting more blood into the heart, you're probably seeing the effects of the sympathetic activity. And we already know that epinephrine also is going to increase the force of contraction. Okay, so both of those are probably playing into Starling's law. Ionotropic effects change the force of contraction without stretching the myocardium, and that's primarily going to be the effect of things like epinephrine. Okay, so when we talk about sympathetic discharge, we have to note that epinephrine has a positive ionotropic effect because it makes the calcium more available to the contractile protein, and it's going to squeeze harder with or without the stretch. But when you add the stretch in to the calcium effect, the force of contraction becomes even greater. Okay, so why does a high venous return result in high cardiac output? Increased blood volume is stretching the myocardium. Increased blood flow into the heart is likely the result of sympathetic activity, and the result is that the squeeze is more powerful, both because of the effect of the stretching as well as the effect brought about by the calcium. Okay, So more in, more out. And this makes sense, right? Because you need more blood pumped throughout the body, especially to the important targets like heart, lung, and skeletal muscle, in order to sustain your activity level. So cardiac output can be increased 4 to 5 times over the resting output, and we remember that that's called the cardiac reserve. Okay, the cardiac reserve decreases as the cardiovascular fitness declines, and one of the reasons for that we're going to find out is that usually in people that don't have good cardiovascular fitness, a factor called the afterload comes into play. The afterload is the force against which the heart has to work, and that's usually greater in people who are out of shape. And the result of that is that the heart rate tends to be rapid all the time, and that also puts a strain on the heart and can weaken it over time. Okay. The changes in volume that take place during a typical cardiac cycle involve the filling and the emptying of the chambers, as well as the change in pressure in those chambers. So we begin with in talking about the ventricles, the time during which the ventricles are filling. Okay, and so this usually happens during what we call the period of relaxation. Okay, the ventricles are in diastole, their volume is increasing because the muscles are relaxing and blood is flowing in. So at this point, what's happening is that the blood volume in the ventricles is going up, okay, and the pressure in the ventricles is going to be rising, all right, but not at a tremendous rate. Okay. Then what will happen at the end of diastole is that the ventricles will begin to squeeze. Okay. And when they squeeze, we're going to undergo a period during which the volume in the ventricles doesn't change, because both the atrioventricular and the semilunar valves are closed, but the pressure goes up dramatically. All right, and this is the period of isovolumetric contraction. So the ventricles here are in systole, and then we'll eventually get to a point where we'll open the semilunar valves, and the volume in the ventricles will go down, and the pressure will initially rise but then fall, and this is called the period of ejection. Okay, so what's happening here is that the volume of blood is steadily dropping, and the pressures will initially rise but then drop as more blood escapes from the chamber. Okay? So the ejection fraction is just the percentage of blood in the ventricle that is pumped out by the heart. A normal fraction is 67%. Exercise will increase this, and heart failure will decrease it. The reason being that in heart failure we damage musculature in the heart and replace it with scar tissue, and the result is that you can't kick out as much blood in the future. Okay, an important point about the ejection fraction is that there's always going to be some blood in every chamber of the heart. If there weren't, the heart would fail, because it would essentially get to a point during its cycle where there would be essentially air in the line, right? And the chambers would seize up and quit. Okay, in fact, this is an excellent way to kill somebody, is to put a huge air bubble into one of the vessels that return blood to the heart. Okay, so the pump is always primed. There's always some blood in each chamber. It's just that the amount of blood changes as the chambers increase and decrease their pressure. Okay, the afterload is just the pressure against which the heart has to work. Okay, so you've got factors that affect output being preload, contractility, and afterload. Okay, the preload is the end diastolic volume in the ventricles at the end of the filling phase, when the ventricles are in diastole, when they're relaxed. Okay, and then the end systolic volume is the amount of blood that is in the ventricles when they've done the full squeeze. Okay, so the less blood that's in there at the end systolic volume, then the less, um, then the greater the cardiac output is going to be. Okay, um, the afterload is the pressure against which the heart has to work, and this is increased in individuals that have atherosclerosis and who are obese. And the reason for this is that in atherosclerosis, deposits on the walls of the arteries narrow them and increase the resistance in the system, and so the heart has to work harder to open the semilunar valves. And in individuals that are obese, the blood vessels don't become more numerous, but they get longer, and that also increases the resistance in the system. If the resistance in the system becomes extremely high to the point where the semilunar valves can't open, we call that congestive heart failure. Okay, and so that's a distinct condition from a myocardial infarction. Okay, in congestive heart failure, the heart is trying to pump, but it's unable to. In a myocardial infarction, it's generally the result of a lack of blood flow to the heart itself. Okay. Note that we have some terms that we use for the effect of drugs on the heart. We have positive and negative ionotropic effects. Okay, so that's a change in the contractility. It's not the result of stretch. The chronotropic effect is one where the heart rate will go up or down. So a negative chronotropic will drop the heart rate, and a positive chronotropic will increase it. And a dromotropic effect is a change in the speed with which the impulses travel from the SA to the AV node and through the bundle of His bundle branches in the Purkinje system. Okay, so all of these, if they are positive ionotropic, chronotropic, and dromotropic effects, are going to increase the cardiac output. Okay, if they're negative effects, they will decrease the cardiac output. Okay. Digoxin, for example, exerts a positive ionotropic effect and a negative chronotropic and dromotropic effect. The reason that you would want to check a patient's heart rate before administering digoxin is that it slows the heart, and we want to avoid a heart rate of less than 60 beats per minute, because that's not compatible with life. This is one of the reasons that we have to worry about the conduction system integrity, right? If the SA node for some reason fails us, the AV node can still run the heart at an intrinsic rate of 60 beats per minute, and that's not optimal, but you'll still be alive. If the AV node goes out, we have an immediate medical emergency, because now the heart rate is going to be so slow that you're not going to effectively pump blood at a rate that will keep you alive. And at that point, we have to use a pacemaker in order for the heart to work properly. Okay. Remember that the SA node is under the superior vena cava in the right atrium, while the AV node is at the top of the interventricular septum at the intersection of the atrioventricular and interventricular septum. Okay. And that the myocardium is going to be activated by norepinephrine due to the positive ionotropic effect, right? It's going to squeeze harder. There are receptors for adrenaline that have different effects. We have positive chronotropics, positive dromotropics, and positive ionotropics. And if we block those receptors, these effects will all become negative. Beta-1 adrenergic agonists activate receptors. A beta-1 adrenergic antagonist will block the activation of those receptors. And so you can determine what the effect on the cardiac output would be, right? A beta blocker can be administered to someone having a panic attack, because the drug will block the response to the firing of sympathetics and the heart rate will slow down. Okay, so a lot of people take this as a way to avoid um, essentially anxiety attacks. Okay? The cardiac cholinergic receptors for acetylcholine are called muscarinic. It's important to note that there are no muscarinic receptors in the ventricular myocardium, and as a result, the contractility is not going to be affected by acetylcholine, and um, the heart rate, the intrinsic heart rate of the ventricular myocardium won't be affected either. But the heart rate for the entire organ will be affected, because if we slow the SA node through acetylcholine down to resting level, it'll still fire more rapidly than the AV will. And that's because of the properties of the cardiac muscle cells in the SA node. They depolarize more rapidly than any other set of muscle cells in the heart. Muscarinic activation does not result in a decreased force of contraction because there are no muscarinic receptors in the ventricular myocardium. A patient that's had a heart attack and is severely bradycardic could use an antimuscarinic drug such as atropine, which blocks vagal discharge, which is the cause of bradycardia, and the heart rate would go up. Okay? So sometimes we want to do that in order to maintain cardiac output, in order for the blood supply to the tissues to be adequate. Now sometimes we can have a slowing of the rate or even a stoppage of the rate on either the left or the right side of the heart for a variety of different reasons. Okay, let's take the example of left-sided heart failure. In left-sided heart failure, you're either not pumping on the left side, or you're pumping more slowly on the left than the right. And the result of that is that the blood that's trying to return to the heart, okay, from the lungs, is unable to do so. So what will happen initially is that you're going to get fluid accumulating in the lungs because of the increase in the hydrostatic pressure in the capillaries that perfuse the lungs, and you'll get fluid buildup, which looks like a whiteout on a chest x-ray, and eventually, if this continues, you'll get fluid buildup throughout the body. You'll also end up with a condition known as cyanosis. Okay? In left-sided heart failure, a person may have poor blood flow to the kidneys because ventricular contraction diminishes the pumping of blood to every vital organ. The kidneys then respond to poor blood flow by retaining fluid, and that's going to cause edema. Okay, and that's through, again, the renin-angiotensin-aldosterone system. Okay, in right-sided heart failure, we have a different problem. Okay, in right-sided heart failure, the blood's not coming back to the heart from the body quick enough, and the hydrostatic pressure builds up in the periphery. The result is that you get what we call peripheral edema, which is swelling in the wrists and the ankles, and we also see an enlarged liver. All right, and that's a condition known as hepatomegaly. So, again, note that what happens here is that usually the reason for right-sided heart failure can be traced to things like fibrosis in the lungs, as an example. Okay, either that, or you might have a problem such as stenosis of the pulmonary valve, where the valve is narrow to the point where the right ventricle can't really send enough blood to the lungs. Okay, so there's a couple of reasons why you might have that problem. In left-sided heart failure, we could have stenosis of the aortic valve, okay, or we might simply have plain old congestive heart failure, okay, where we end up not being able to open up the aortic semilunar valve because the afterload is so high, and the result is that the left side of the heart can't pump at all. Right? So those are all possibilities. Next thing we want to look at is heart failure.
Cardiac compromise is a blanket term that refers to many kinds of problems with the heart. Just as there are many problems, there are a wide variety of signs and symptoms associated with these heart problems. As an EMT, it is much safer to treat all patients as though they are having a heart problem, rather than diagnose the specific disorder. With that in mind, let's take a closer look at 5 of the most common heart conditions. Coronary artery disease. Coronary artery disease occurs when the coronary arteries are narrowed or blocked, reducing the amount of oxygen delivered to the heart. 2 conditions, atherosclerosis and arteriosclerosis, commonly cause the narrowing or blockage of arteries. Atherosclerosis is a buildup of fatty deposits on the inner walls of arteries. This buildup causes a narrowing of the inner vessel diameter, restricting blood flow. Fats and other particles combine to form plaque. Arteriosclerosis is a stiffening or hardening of the artery wall resulting from calcium deposits. Often called hardening of the arteries, this condition causes the loss of elasticity, changing blood flow and increasing blood pressure. These conditions can facilitate rough surfaces, making them vulnerable to blockages. A large thrombus can cause an occlusion, or it may break loose to become an embolism and form blockages elsewhere. When blockage occurs, tissues may die, and in certain cases, this can be fatal. Acute myocardial infarction. Acute myocardial infarction occurs when a portion of the myocardium, heart muscle, dies as a result of oxygen starvation. The dead area can no longer pump. This can lead to cardiac arrest, shock, pulmonary edema, or congestive heart failure. In some cases, heart attack patients suffer cardiac rupture as the dead tissue area of the heart muscle bursts open. Medications called thrombolytics dissolve clots that block coronary arteries. Other patients receive an angioplasty, a balloon device, to open the arteries. Aneurysms. Weak spots that dilate are known as aneurysms. When a weakened artery bursts, rapid internal bleeding occurs and tissues beyond the rupture can be damaged. A rupture of an artery within the brain can result in a severe stroke. If a major artery ruptures, death from shock can occur. Arrhythmia. A malfunction of the heart's electrical system will generally result in an arrhythmia. Electrical disturbances within the heart result in arrhythmias, including bradycardia, abnormally slow, less than 60 beats per minute, tachycardia, greater than 100 beats per minute, or rhythms that are present when there is no pulse, including ventricular fibrillation, ventricular tachycardia, pulseless electrical activity, and asystole. Congestive heart failure, CHF. Congestive heart failure, CHF, is a condition of excessive fluid buildup in the lungs and other organs because of inadequate pumping of the heart or of failure of the lungs to function properly. Congestive heart failure can be caused by diseased heart valves, hypertension, or some form of obstructive pulmonary disease. The symptoms of CHF may include tachycardia, shortness of breath, elevated blood pressure, cyanosis, profuse sweating, cool and clammy skin, pulmonary edema, pedal edema, or the coughing up of frothy white or pink sputum. Late signs include engorged pulsating neck veins or enlarged liver and spleen with abdominal distension.
So, with heart failure, we want to strengthen the contractile force of the myocardium, so we can use positive ionotropics here. We want to remove excess water, so we can utilize diuretics. We want to decrease the workload on the heart, and so one of the ways we can do that is to promote vasodilation. All right, so there are all kinds of drugs that will cause systemic vasodilation. Many of these are what are called ACE inhibitors. All right, so what they do is they work by decreasing the production of angiotensin II, and one of the effects of that is to promote vasodilation. And we can protect the heart from excess sympathetic activity, and there are drugs that'll do that as well, and that'll slow the heart rate, and that'll also bring down the blood pressure. Remember that after heart failure, the heart's permanently weaker. So cardiac output's always going to be lower than it was prior to the attack, and the maximum force that the heart can produce is going to be permanently reduced because the scar tissue isn't capable of contraction. Okay? So I thank everybody for listening. Remember that if you have any questions, contact me by email. I'll be happy to help you out, and I'll join everybody in the next podcast. Thank you very much.